Thank you, Christelle. And it's actually a pleasure to follow Jason today. I think he's really laid the groundwork in terms of, what the research is telling us. And, there are probably many factors as to why these different organizations come up with specific recommendations. And, I must say, as I was listening yesterday in and out and listening to Rob and Gabor Mate's conversations, the chronic pain patient is so vulnerable for so many reasons. And we keep looking for the magic bullet. And 5 years ago, I guess, the magic bullet was about to be cannabis. And we know there's no such thing. But do we really have the evidence and the science to make these decisions that are being made consistently and constantly based on RCT evidence to date? And at least Jason has taken the time to go through this and dig probably deeper than most of these and come up with at least the conclusion that we do need some more evidence, and we need to listen to some of what our patients have been telling us for decades in terms of the possibility of parts of this plant helping them. And so kind of with that context in the background, we're left in a scenario, and I'll put up my disclosures first. I will be speaking a little bit later about a bit of the work that I'm doing with Shoppers Drug Mart in terms of a national platform that we can recruit patients and gain some of this observational data moving forward. And so there is a bit of a conflict there. Beyond that, not much else with a significant conflict. Jason touched on October 2018. And, once we made cannabis recreationally available in Canada, it unfortunately put a dent in what we were hoping to do on the science side. And that really was to start to study what our patients have been telling us, what the lay public has been telling us for the decades leading up to this, that this plant has been helping their pain in some way. Jason's point about inhalational use is still a strong one. Many patients are gravitating to inhalational use. I'm not going to spend much time on this other than to say that we know that the endocannabinoid system is is part of our nervous system that transcends just your brain. You have endocannabinoid receptors in your gut, you have them in your joints, and it makes sense that people are going to see effects solely beyond how it has been studied for decades before. I'd like to just put up this slide because it resembles any product monograph that you might see for many of the pain medicines that we treat our patients with. You have a pre and a post synaptic membrane. You have an anandamide, which is our naturally occurring endocannabinoid that works on that CB1 receptor. And what does it do? It's a CNS depressant. What are many of the medications we use in pain? They are CNS depressants. And so when you hear the stories that Jason has touched on in terms of the possibility to help individuals wean their opioids, or the possibility to help people wean their benzodiazepines, it's what we see when we add various medications to any pain patient's regimen, when they come in for treatment. And so it's not a big stretch that these medications will have that role. It's how we go about gathering the evidence and the data to do this safely. And in general, how we ensure our patients get safe and reliable and validated products to be consumed, and not any product at their corner store. And so a lot of what Jason presented to you comes from these types of products. And some of them are DIN products, drug identification numbers that Jason talked about, that we can prescribe. So nabiximols in particular, or Sativex, is probably where most of that randomized controlled trial data comes from. And recently you have the Epidiolex drug in the US, which is a CBD extract that has now been approved in the US as well as the UK. We are yet to do that, and I don't think that we will anytime soon in Canada. When you look at the data Jason presented, and he's really talking about there's now 317,000 individuals that have a license to use cannabis. When you ask the Canadian public, the last consensus statement was that 3.1 million Canadians are using cannabis for a health-related condition. And so that would leave us with 2.6 million Canadians effectively self-medicating with recreational products and getting advice from, whoever it is that they encounter that tells them you should consume this product for your rheumatoid arthritis, or you should consume this product for your epilepsy, et cetera, et cetera. And so that's not a great place that we currently are in Canada. And unfortunately, when you look at where we are moving very slowly at rekindling the science aspects. And, at least the regulators have now given us the ability to move down the path of using some of these products that patients are claiming benefits for in some of the trials as we move forward. And Toronto, the epicenter of many things. I know you'll hate that, Rob, but we also lead in terms of $334 million spent on cannabis products last year. And the predictions of where this industry was going to get are actually, Christelle, I see the laugh, are actually 2.6 billion in terms of legal cannabis sales in Canada. So we are in the billions of dollars, and this is the path we have taken as a country. So when you look at the potential places that we're using cannabis, or patients are using cannabis, I should say, pain is front and center. PTSD, Jason, has a big hand in the vet world. That's been one of the primary areas that the government has decided to put money into funding. We haven't yet started to fund in the seizure world the way Epidiolex has been funded. But as a physician, you can see how your patients, as they gravitate to wanting to know more and having access to this product in almost every corner store in Canada, will head in the direction of using cannabis in various conditions. And so I'm just going to touch on this slide. We did a quick overview of about 600 consecutive patients that came through our institution. 1 in 5 individuals coming in for a joint replacement surgery were using cannabis. And so we knew that we needed to create some guidelines. This was something I talked about last year, I think, at this Pain Society meeting, in terms of how we would go about dealing with these individuals in the operating room. And so it's out there for you to take a look at if it's something that interests you. But what I really wanted to focus on is, what we're doing, not only in the kind of seeing patients and treating them clinically, what we're doing in terms of some of our team grants that we were able to get here. And I know that Jason's work was funded through this same competition. And so we're a year into looking at different mouse models and different consumption in different formulations, in terms of seeing where and how these cannabinoids are getting into our tissues. And I can tell you that what was interesting in some of our data is that we're seeing some pretty interesting chondrocytic sparing activity in some of these rat models with our THC products. And so this is early data. You'll see a couple of abstracts coming out now, and the fact that the oral systemic route is actually better than some of our intra-articular injections. We've started to recruit patients coming through the operating room and taking samples of their synovial fluid as well as their meniscal tissue to see if any of these endocannabinoids or these cannabinoid products are actually making it to the tissue level. So, some pretty cool stuff that I think you'll see come out over the coming years. I wanted to stop and focus on this manuscript that we published in May of this year. And it speaks to what Jason was talking about. And we really had no other way but to collect observational data in Canada. And this was a 4-year study of which we recruited 1,000 patients. And I'll talk to you a little bit about what we saw and some of the struggles. So we enrolled about 1,000 patients. Of those 1,000, 757 patients completed the baseline. Beyond that, only 396 of these patients actually made it to 3 months. And you can see the number continue to drop off over time. And one of the biggest weaknesses and one of the biggest barriers to publication, and Jason touched on this, was the amount of drop off we had long term. And so I made the argument that if you have a patient population whereby which 1 in 3 individuals that consented and purchased a product stayed on it for 6 months, there is some kind of signal there. And no, we would fail completely the evidence and the risk of bias probably statements when you hold it up to some of the standard nomenclature, but the fact is that is exactly what we saw. And so, as Jason said, 90% of this population were seeking cannabis for chronic pain. When you look at what they were typically using, and remember, this is the time, this was very early in our cannabis journey in Canada. It had been legalized, but not yet recreationally available. So the most of these patients were using an inhalational product. And when you can look at the amount that they consume, you're looking at less than about 2 to 3 grams a day. Most of them actually, almost 70 or 60, 70% of them were using less than 2 grams a day. And what was even more interesting was that as you looked at this evolution in terms of using this over the 3 months, 6 months to 12-month time period, patients gravitated from their dried products typically onto oil products, whereby which about 50-50 were using a dried and an oil product by the end of this kind of observational look at what was happening. This was run by the Cannabis RX clinics. We had no oversight as to what was happening in this Ontario patient population, but it was it was remarkable just to see the evolution. And when I hear people talk about inhalational products and how much people are using, when you get into the 5 and 6 grams a day, as is being covered for many of our vets, you're getting into areas where you're definitely going to see some of those significant side effects. And so something to think about as we continue to talk about covering cannabis for individuals in Canada moving forward. So the ultimate question about, does this help with your opioid weaning? Do you see people using less opioids? Well, it was pretty clear that, we don't have the numbers per se that Jason had in terms of 20 milligrams or none. We have a simple yes, no in terms of were individuals using an opioid at the time they enrolled in this observational look forward. And I can tell you that it was about, 60 to 40, 50, 50 in that ballpark in terms of individuals that were using opioids at the start of this. And you can see, obviously, there's going to be a response bias for those people that stayed on their cannabis products, but about 80% were no longer using cannabis of those that continued along this journey of using cannabis. And so again, observational data, no one's going to change their recommendations based on this. But again, where there's smoke, there's probably fire. And how do we go about getting the evidence? So in a nutshell, about 1/3 of the patients in the cohorts were the ones that continued on their cannabis. And so 1 in 3 individuals who even started stayed on it at some level. Overall, there was a reduction in pain intensity, pain-related interference, and even an improvement in those that, again, remained in the trial with respect to quality of life and general health symptoms. Jason touched on the consensus statement looking at opioid prescribing. We have just published this in the Journal of Cannabis Research, and it again is another Delphi put together with many of these docs that you'll see here, Arun Bhaskar being the head of the British Pain Society, and coming together to talk about how you would go about safely implementing cannabis for chronic pain. Again, this is in the context of all of those recommendations that Jason presented to you previously. And so, this can be called into question at all time, and I'm sure it will. Why do we lead with CBD? And CBD we lead with from a harm reduction standpoint. And there are some types of pains that we do see patients come back to us, surprisingly sometimes, and say, we're seeing some benefit with using CBD-based products. And then we work on integrating THC into their regimen. And obviously there are caps to which and to how much patients should be using before you really start to involve a pain specialist. So let's talk about a little bit more about this I asked statement. And so what I can say is, when this came out, I looked through the names and I went directly to Ian and I said, Ian, how does this help us in Canada? So you have a country that has now had a recreational platform. You have a country that has 2.6 or 7 million people self-medicating with cannabis products. And the duty and the mindful thing to do was to warn physicians from using this product in a chronic pain population, in a vulnerable pain population that is already at risk of going after the next best and greatest medication that comes to market. And so I was pretty upset with it. And I think my hope is the reason they did this is they do not want to follow in the footsteps of what Canada did and have all of the jurisdictions in Europe open this up recreationally and lose the ability to do the science. And so that is hopefully one of the reasons that they landed in this position, beyond the fact that if you actually look at the data the way Jason presented it, you are not comparing apples to apples. You're actually looking at products that were done from a preclinical standpoint or other molecules other than what patients are currently using. So what did we try to do? And this is something we worked on for the past 2 or 3 years. This is still enrolling actively. We have a few hundred patients in this. We're aiming for 2,000. And we were also hoping that we could get, from coast to coast, patients enrolled in a prospective 6-month journey with cannabis with validated products. And this is done through the Shoppers Drug Mart medical cannabis portal. And any doc anywhere in the country can prescribe. We're collecting anxiety, sleep, quality of life data, and obviously pain data. And what we're aiming to do here, and the beauty of this portal, is that it's all done online. The consenting is done online. Everything can be done with your patient via an online platform. And the hope is we would get both those that continued on their cannabis and those that did not. And at the end of this trial, they would each get, a gift certificate for completing the 6-month journey. And, we were really stuck. This was really our only way forward at that point in time. And I'm happy to say we are still continuing to recruit, and anybody interested can please reach out to me directly. This is the part where you consent online, and we created a specific microsite for this for patients and for physicians. And so if you went to that website that's at the top banner here, you have a patient page that explains exactly what you will be doing on your 6-month journey through this study. And we have a healthcare practitioner page. And I think this can be leveraged for so many things. We're about to bring some neurologists on board to start tracking some of the epilepsy patients that are trying to use cannabis as well, and CBD in particular, obviously, for their conditions. And so over time, you can see there is a big opportunity here for us to at least get that observational data based on what Canadians are using and what our licensed producers are making. Jason finished up, with a very important statement, is that we need to understand where we can get information to help practitioners. And so this was launched also in the spring of this year. And I was part of the Canadian Consortium for the Investigation of Cannabinoids, and I am a board of director with them. And so these are the folks that came together, and it was a 2.5-year process to put together a CME accredited cannabis education lecture series. And so I can tell you that we have 9 modules. One of them looks at the endocannabinoid system and the Cannabis 101 basic science from any of the docs out there that are struggling with knowing, how do I even start a patient? Maybe I don't want to send them to that specialty cannabis clinic down the street. I'd actually like to see some of these effects with my patients. We look at this from a completely balanced perspective. So looking at the long-term health outcomes associated with cannabis and the data that's out there. We look at it both from pain and non-painful conditions. So obviously epilepsy is front and center in some of that. And talk about what you should actually think about if you're actually going to go down this road with your patient sitting in front of you, and what would be suitable for different patient populations. Talk about drug interactions, some of the things that we're really concerned about, a bit about pregnancy. There's so many areas that we touch on, and of course, we couldn't finish this 9-module CME without talking about cannabis use disorder. And these things all exist. We know they exist. They were what we studied front and center for 3 decades in terms of adolescents using high-dose cannabis that lead to first onset schizophrenia. And there's no doubt to any of that data. And so what we do know, though, is that in an adult brain using significantly lower doses, that this can have other effects. And just like every other compound that we use in medicine, we repurpose them for the places that are helpful and stop using them in the ways and in places that they are harmful. So finally, for the Canadians, there is a cannabis policy module as well. So, you can easily find this syllabus on the CCIC website. So I want to just finish off with a general overview and round back to Jason's discussion about opioid weaning. So let's talk about the interrated pathophysiology as to why there may be some benefit to this. And we both know that we have cannabinoid receptors as well as mu-opioid receptors that overlap in the dorsal horn, in the locus coeruleus, in the dorsal striatum. And we also have a ton of basic science data looking at CoA activation of these receptors and opioid sparing effects of medical cannabis. The animal literature, there's no debate. So, where we lack, obviously, and where no one wants to stick their neck out is to actually have that human RCT data. And it's one of the things that, we have been trying here at this site. And, to Jason's credit, he was very kind in sharing one of his Health Canada documents that enabled, I think, his group to start a couple randomized controlled trials. But, are you going to use cannabis in all patients to help wean their opioids? We can debate this number of 25 as the lower limit. There are reasons that you may go under that, but for the most part, that is still what Health Canada recommends. Obviously a strong history of, psychosis and other psychiatric comorbidities are a problem. The data on pregnancy is pretty clear. You don't want to be using cannabis in that first trimester. Although, if you were to Google that, you would see that Dr. Google would tell you that it is completely safe in that first trimester while your fetus's musculoskeletal system is being developed, when there's a ton of animal data to speak to the opposite. So, these are areas that, again, we need to continue to collect data to ensure that what we're saying and what patients believe are actually accurate. Jason pointed out this consensus statement that we put together on tapering opioids for chronic pain, and in general, looking at what you would actually do in a patient based on their opioid dose and how you would go about doing this. And so I'm not going to walk you through this demographic here, or this diagram, sorry. And I can tell you that, similar principles to what we touched on in the chronic pain population. So, likely initiate again with some CBD dominant products, some guidance in terms of how you would go about adding in some THC with some of your patients, understanding what they can and can't do when you actually add THC, and then how you would potentially go about tapering. Now, Rob and I kind of land in the same place in terms of how we taper our patients. I'm not a fan of algorithms that say you should be doing 5 to 10%. I'm happy to work with my patient. And so from a protocol perspective, though, we did have to come up with some type of potential scheduling, given one of the things we are trying to do, and I think we're pretty close to, is launch finally a CIHR funded pilot study that we've had now for 2.5 years, and I was about to give the money back. And I do think we might have an opportunity using some products established in the marketplace to get this done over the next year and potentially move us forward to one day have one of those RCTs and look for partners to do something on a larger scale at that point in time. So, that was kind of a whirlwind. I have lots more to say, but I'm going to pause there. And I'm going to say, I think we've left a good bit of time here for questions, and I'll turn it back to Christelle, and I guess Jason will be joining me again.